Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome everyone to another episode. Today I'm with Dr. Tom Stone. He is an oral and maxillofacial surgeon practicing in Denver, Colorado. Tom, thank you for joining us again on the podcast.
Great to be with you, Grant.
Yes, love the episode we did last time, kind of talking about streamlining referrals, using the DoctorTalk software to do that. And I mean, if anything, just kind of bringing our attention to that topic of capturing all the referrals and making sure we're getting to them in a timely manner, no matter what, system we use. So that was some cool stuff. Today we want to talk a little bit about kind of your philosophy and the way you handle immediate implants. So could you talk to us a little bit about that ability to offer an extraction and an immediate implant in one appointment versus staging it?
Yeah, thanks, Grant, for the kind comments. I think everything that we do, we try to gain consumer confidence, and I think all of these things that we've been discussing really just underscore the importance of efficiency, the importance of just making the whole implant process easier for the patient. I remember when we started doing implants, or when I started doing implants 25 years ago, we would graft and wait 4 to 6 months, and then we'd put the implant in, we'd wait it was almost a year before the patient got their tooth. And we didn't always one-stage implants. Sometimes we'd two-stage them, and we were reticent to put a healing abutment on the implant. I mean, all these things that we take for granted now are just things that we kind of had to learn early on. But what I've learned is that when we make the process easier for the patient, they follow through with treatment. And it's one surgery versus two. It's less cost. There's fewer appointments for the patient. And I think it's just a great solution for the patient. They receive a solution for their missing tooth the same day that the tooth is removed. And so I think the key is just simplicity and giving patients a great solution.
Love that. Yeah, what a great thing to offer patients. What role does digital workflow play in your system of doing immediate implants for your patients? Do you use digital tools for that?
Yes, we actually started doing digital workflows in about 2009, and it was a big shift for our referring offices. It was a big shift for our office. It took a lot of building systems in the office. I think a lot of specialists and dentists, for that matter, they think, "Hey, I'm going to buy a scanner, and my practice is going to grow." And I think with any technology that you have in your office, you have to have a system to implement that technology. And so that's, I think, where we've been really successful at implementing a digital workflow, is not just buying a scanner and then it becomes a really expensive coat hanger in the corner of your operatory, but instead, like, really having systems, business systems with your referring offices, who are your business partners in the community, and then implementing those systems so that the patient has an easier process, but also so that the referring dentist is profitable in the process, and it's just a smoother experience for them. And so I think it just makes the clinical process more predictable and more efficient for the dentist and the patient. So,
do you use anatomic scannable abutments, or what are you using with that?
Yeah, we used to, when we started doing a digital workflow back in 2009, 2010, we were using the Biomet Encode abutments, which I think adds simplicity to the process. You don't have to take off a healing abutment and put a scan body on. The patient comes in, you test the implant, you scan it, and they're out the door. And so I think that you know scannable abutments have been something that's added uh, just efficiency to the process. And the smart shaped healing abutments, they also just provide amazing tissue contours. Um, I'm actually teaching a course on extraction mediated implant in the next couple of months with Dr. Katie Lee at the Collective Health Society Education Center, and it's going to be fantastic. But we're going to talk about smart shape healing abutments, implementing digital workflows, and the emergency implant. She's actually going to publish more on that in her Doctor Talk channel. So if you go to the Collective Health Society uh, channel on Doctor Talk, she'll drive some additional information. So
Nice.
little plug for the course.
Yeah, that's great. Um, and then, what are some of the ways that you can help kind of streamline this workflow for office teams without getting them overwhelmed? Do you have any tips on that one?
That is actually a really good point. And I think, as with anything, success begins with education and training, not just on the protocols, but also utilization of the digital technology. So I think training your team with patient benefit driven scripting, um, helping them to just have the conversation with the patient. Have you thought about a solution for your missing tooth? And then a lot of patients haven't had that conversation. They're just referred for, an extraction. And it's not all about revenue. It's about providing the patient with a great solution. But if you think about it from the business side, you know, the least productive thing we do in oral surgery and dentistry, I think, is, you have a patient come in for a consult, you take out a tooth, and then the patient walks out their door, and it's, a few $100s of revenue for the practice. But if you atraumatically remove the tooth and you're able to place an implant, your encounter with that patient is almost 10x what it would have been if you just took the tooth out. So again, it's, I think from a business standpoint um, for oral surgeons, periodontists, dentists who place implants, that's a great business growth tool. But I mean, it's not like you're doing something that isn't in the patient's best needs or in the patient's best interest.
Okay. Um,
Oh, I think the other, like another good point there, Grant, sorry, I didn't mean to interrupt you, is
yeah.
I think, if you're going to start implementing this in your practice, begin with, single tooth, straightforward cases, maybe a conical premolar. And, I think making sure that your communication between the clinicians, the digital labs, the teams is, aligned, and I think that really builds confidence with the patient. So team training, is important. And I think it just helps drive the process. And then once you have that locked in, then you just keep doing it over and over again, and it becomes a very routine part of your practice.
And that was actually my next question was, because there's can be a lot of variability between patients, between which tooth you're taking out, and if we can do an immediate implant. So how do you streamline that for your staff and the patient? Because let's say they're having a molar extracted, and the staff isn't sure what to say. Should we even offer an immediate implant? And like, how do you help that process so it's not giving the patient like 50 different options and they're kind of confused about what we're going to do?
And that's you just hit the nail on the head, is taking out a tooth and putting an implant in. Most of us are trained to do that. That's not the complex part of the emergency implant. The complex part of the emergency implant is the communication with the patient. Because let's say you come into my office and I say, "Hey, Grant, we're going to take out your tooth and we're going to put an implant in." And you say, "Awesome, I'm super excited about that." You go to sleep, you wake up, and the implant's not in. Then you kind of look at me and like, "What'd you do wrong? Did something not go right? Did something happen? I mean, you told me you were going to take out my tooth and put an implant in." So I think having that conversation about, plan A, plan B, and it doesn't have to be complex. You don't have to say, "Well, if we lose the septal bone, or if we lose the buccal plate, or if you have thin biotype." I mean, patients don't understand those words. So we have to simplify our communication with the patient. And, what we say to the patient is, our plan is to remove the tooth and place the implant. But if for some reason the bone is a little soft, or the area has been too inflamed or too infected, and it doesn't meet criteria, then we're going to do a graft. And I just want you to give me the flexibility to make the right decision for you. Just taking 30 seconds and explaining that to the patient, they'll always look at their clinician and say, "Yes, Dr. Stucki, I trust you to make the right decision." So that's an important conversation. And maybe you even have that conversation not just at the consult, but you also have that conversation, during your timeout. We do a timeout before every surgery. And so you do a little timeout and you have that conversation again. Our plan is to place the implant, but if it doesn't meet criteria, give me the flexibility to make the right call. So that's one part of it. Then the whole second part of it is the business side. So, you give them a treatment plan that is, "I'm going to take out your tooth and put your implant in." But if you end up grafting, there's a whole bunch of questions for your team. Do you charge the patient for the graft? Do you have a staging fee that then kicks in? And, I'm not going to tell anybody how they should run their business. That's a very personal part of dentistry, oral surgery. What we do is, at the consult, if I look at the x-ray and I do a physical exam and I know that I can place that implant, then I say, "We're going to take out your tooth and put the implant in." Now, if I get into surgery and for some reason I'm not able to do that, I don't charge the patient extra. I always tell them, "I'm going to treat you well and we're going to treat you fair." So if we have to stage it and come back in 3 months, we're not moving the goalpost on you. And that works in my practice really well. And I think patients appreciate that. If you're a little bit, you don't want to give the farm away, obviously. And if you're not sure about your ability to place implants, I think you could have a different script. And you just say, "We're going to take out your tooth. We're going to be prepared to graft or place the implant. If we graft, this is what your cost outlay will be. If we're able to place the implant, then this is what your cost outlay will be." So you give them, or plan A, plan B. I wouldn't say option A because it's not their choice, but plan A, plan B, or a backup plan. And if the implant goes in, hey, it's a win. You save them an extra surgery and you've saved them cost. But how that's scripted is really important. So I'm really glad you asked that question, because I think that goes to the heart of, I think as I teach immediate implants to a lot of clinicians, that is the obstacle. It's not the surgery. They're able to place the implant, they're able to do atraumatic extraction, but it's actually the scripting.
Yeah, for sure. Such a key part to make sure the patient's understanding everything, to do it in a simple, streamlined way. That's really good. There's two different terms here. There's the emergency implant and then the immediate implant? What is the difference between the emergency implant and extraction versus the immediate implant?
Again, great distinction to make. In about 2007, Lee Walker wrote an article called, or is entitled, "The Emergency Implant," which, in that article, he basically said, the emergency implant is, the extraction of an infected or non-infected painful tooth, placement of an implant into the extraction site, which effectively addresses, not only the painful tooth emergency, but it provides a definitive solution for the patient's missing tooth. So that's kind of an emergency implant. Immediate implant placement. When we started doing immediate implants, it was back in the early 2000s, and the only thing that we really had to go on were the dog studies done by Botticelli, and his question was, does the bone fill in? And so, there were some pioneers in extraction immediate implant. I think, Lee Walker, Gary Morris, Nader Movanian, Craig Yamamoto, Russ Lieblich, all of these guys were like pioneers in extraction and immediate implant placement. And, I think immediate implant placement has become kind of a staple for a lot of oral surgery practices. Immediacy is a very common term we use, which is really a non-emergent procedure. But I think that, to really be a good full arch surgeon these days, you've got to be able to, remove a tooth atraumatically and place an implant. And so extraction and immediate implant, I think, helps the clinician just, become better at full arch surgery. And sometimes we get difficult extractions. The tooth's hard to get out. And, I remember Dr. Hildebrand at Chapel Hill when I was in my third year dental school learning how to take out teeth. He'd always say, any tooth will come out if you remove enough bone. And the key is not removing bone, but getting the tooth out, preserving the bone and the soft tissues. And one of my oral surgery partners, Dr. Arsenault, sometimes we complain about that root canal treated number 14 that just humbles us. And he just says, I love it when the extraction is difficult because it's better bone for a titanium solution. So, if you're complaining about taking out a difficult tooth, just think about how much better the implant's going to be because you've got a good foundation. So anyway, that was kind of a long answer, but hopefully that addresses the question.
Yeah, that does. And then you're kind of alluding to it, but in what ways does kind of being able to do immediate implants differentiate you potentially from other practices, doctors that maybe don't do immediates or aren't as I guess you could say aggressive or fluid with doing immediate implants?
Yeah, I think just being able to offer a same day solution, with the support of advanced technology sets you apart. But also having, business systems with your colleagues in the community, with your lab, and it distinguishes you, I think, as a progressive, patient-centered office, and that is, responsive to patient demands. Increasingly, I think we're a B2B community as oral surgeons, but I've seen a big shift in recent years where it's really having satisfied patients that can give you a 5-star review. It impresses the patient because their experience is better, their convenience is better, and the patients actually become advocates for your practice. And so over time, that organically builds your reputation, and I think it builds referrals for your practice. we use our Doctor Talk app to with the AI powered intelligent referral management inbox. So everything goes into one place, but part of that is also patient submissions. Patients can go to your website, and then when they submit a self referral, that lands on my phone, and it's like, wow, I just got a patient just self referred because they heard about our immediacy, about our emergency implants. So that's always exciting for me to see. I can see that immediately, and I just have seen that type of organic growth. In fact, I think my our top referring source now is actually previous patients who are referring family members and friends. So,
Wow.
so I think, and I talked about this a little bit earlier. From a business side, you make the entire dental team more profitable. You get the patient back to the restorative dentist in 2 to 3 months with a crown and an abutment. That's a great that's a great service. And again, we use Doctor Talk. When we send a surgical release to a dentist, they get it on their phone. Like they literally get a message saying incoming message or surgical release from Colorado Surgical Arts or from Dr. Stone, and it becomes a call to action. And patients love that type of efficiency. They're like, wow, I just got my scan and you're calling me already. They know that there's a great system there. So so I think you make your business partners more profitable, whether it's your referring doctor office, your lab, but even the implant company wins when we drive efficiency in the process. So I think that's probably how it sets you apart.
Okay. I mean, I've heard surgeons who really don't do many immediate implants say that, they just feel like there's higher failure rates. They feel like the bone doesn't quote unquote fill in. It's not great results. How do you maintain like quality control with doing immediate implants?
Well, I think that's also an essential part of I think anything that you're doing is you want to have high quality. And that's a great question because I actually asked my younger partners when they joined us. I said, why are people hesitant to do immediate implants? And I think it's kind of, I mean, this is a really basic analogy, but when you're doing carpentry and you screw a screw into the wall, you like to engage the wood, and the wood provides stability. With implants, we like to put the implant into bone, and we like to have that primary stability. It gives us a lot of reassurance as clinicians that, hey, we've got 100% circumferential or 80% or whatever bone to implant contact. And the difference is that we have such great technology with our implants nowadays, and the healing capacity of an extraction site is tremendous. And so, does the bone fill in? Yes. I mean, Botticelli's studies show, I mean, when they did those dog studies back in the early 2000s, they would place implants and they'd create a defect around the implant. And some of those defects they wouldn't graft or use a membrane at all. Some of them they would just graft, and then others they would do a graft and a membrane. And the size of the defect I think was like 1.5 to 2 millimeters. And what they realized was it didn't matter if you grafted or not, that the bone actually filled in. Now, we know from just rigid fixation, facial fractures, all the studies that have been done on osteoblastic jumping distance, that it's probably 2 millimeters. Tarnow's confirmed that with some of his more recent publications, and has even suggested that it might even be greater than 2 millimeters. But I think 2 millimeters is kind of our standard. So if we place an implant and we have good stability and our gap is less than 2 millimeters, I still graft those. I still put like, cadaver bone in, um, and then I'll put a little membrane over, suture the tissues, get primary closure, and it heals great. I mean, so does the bone fill in? Yes. Um, Obviously, another essential part of immediate implants is just making sure that you curette out all of the granulation tissue. I mean, you can't leave granulation tissue, and I've made that mistake in the past where maybe I haven't been as meticulous with that. I my colleague Mike Burnham got me using loops about 5 or 6 years ago. Changed my life. I was like, wow, I don't, not sure if I knew what I was missing before I started using loops. But I think being really meticulous about debriding the socket, having good, healthy bleeding bone, and good attached tissue around the healing abutment. I think those are really important, facets of quality. Obviously platform depth, understanding your anatomy, your anatomic landmarks, pre-op planning. Those things are all an important part of quality assurance. So, I mean, and I'm not giving a plug for our course, but those are things that we talk about in the course. Putting an implant into somebody is a permanent footprint. And so if it doesn't look right or you're not happy with the with the result, remove it. Remove it and graft it, send the implant in and get another one and have the patient return. So I think, absolutely patient quality has to be at the forefront. It's not about, oh, I'm going to fire this implant in, I'm going to, make some money today. It's got to be what's going to be best for the patient. But if you put that first, then you will also be successful. So kind of, again, long answer, didn't mean to ramble, but hopefully that uh, answered your question about quality control.
Yeah, that's helpful. I mean, maybe a bit of a technical question, but um, for because I think I'm very comfortable doing these on single rooted teeth. I've done many molar immediates as well. But what do you have any specific tips for doing like a number 19 where you've got a pretty large defect there and maybe it's implant size? I know different companies have different widths and things like that, but you shared curetting out all that granulation tissue and probably dropping that implant um, a couple of millimeters or whatever below the crest. What other things would you say as far as having success with like a multi-rooted tooth area?
Yeah, I mean, I think those are essential parts of immediate implant placement. I mean, you want your implant, you don't want your implant position to be compromised because you're placing it immediately. And when you're looking at your pre-op planning, what's a good case to maybe start with is I don't think you want to have a case where the inferior alveolar nerve runs right at the apex of the molar roots. Maybe get a little bit of running room below the apices of the teeth, just so you have a little bit of a comfort zone. Always check your mylohyoid attachment. Some people have a high mylohyoid attachment and they've got a really significant undercut. So you look at a panoramic radiograph and you think, gosh, I've got, tons of running room, but you really don't because you're going to end up drilling into the floor of the mouth. So I think, now that we have cone beam CT technology, that certainly helps avoid those types of errors. And if you don't have a cone beam CT, then just do a good physical exam and take a few seconds to look down the lingual wall and make sure it doesn't, cut under. Just put your finger under there and make sure you don't have a significant undercut. So I think, back to your question though, running room, I think having the buccal plate intact, uh, atraumatic extraction is important. And then just putting your pilot drill usually right in the septum. You want to get primary stability. So where are you going to get primary stability? You're either going to get primary stability, apically, or you're going to get primary stability buccolingually because your average molar site is 10 millimeters. your implant is, whether it's 5, 6, 7, or 8, and we have all of those solutions now. Um, you're probably going to engage in the buccal and lingual cortices, which is great. And then you've got, if you've got a 6 millimeter implant and a 10 millimeter, you know, defect, you've got 2 millimeters on either side. Is that going to fill in? Yeah, it'll fill in. Do you graft it? I always like to just graft it. I sleep better. I just feel like I've filled in the gaps better. So, um, does that help a little bit with kind of like molar placement? And then, maxillary molar and management of the posterior maxilla is a whole different animal. And I think just having solutions for your management of the posterior maxilla, whether you're doing a vertical lift, whether you're using densiburs, and going in reverse and just increasing the height of bone, or whether you're doing a lateral window sinus lift at the same time that you put an implant in. And then when do you use each of those different techniques? Those are, again, not plugging the course, but those are things we talk about at our immediate implant course. And if you're not sure, find somebody who's doing it well and go and learn from them.
Yeah, exactly. Yeah, that's really helpful. And awesome that you're offering a course to really delve into this. That's pretty cool stuff. How does the doing the digital workflow and offering the immediate implant in this whole system that you give, how does that create, like a great experience for patients? Have you found reviews or feedback from patients? What are your thoughts on that?
Well, I think we're all, review sensitive because we love positive feedback as clinicians. I think I have a really great mentor who once taught me feedback is a gift, and so you have to take it as a gift. And sometimes you're going to get great feedback, sometimes you're going to get not so great feedback. Um, but always take it as a gift and use it as an opportunity to improve. So we love the 5-star, reviews, and we love those experiences, but sometimes it's the 3-star reviews or the 2-star reviews that actually give you an opportunity to learn, hey, what could we have done better? I think as far as, how does this drive a 5-star experience for the patient? I think just minimal disruption to their lives. We all, our lives are going really fast, and people want things immediately. They use, Amazon, and they click a button and things land on their doorstep. And I think they want that type of experience in dentistry, where I don't want this to, I've got a business trip, or I've got to travel, or I've got, you know, a concert, whatever it is, they want minimal disruption to their lives. And so, giving them a clear and simple treatment plan, and then also providing, clear and confident communication through the process, I think gives them that 5-star experience.
Yeah. I love that you're thinking this way, or I feel like you're always thinking about how we can, like you're saying, minimize the disruption, how we can make their lives easier. And I think that's a good way to do it. The other end of it is, the traditional way of just thinking, well, here's how we do it, and the patients, kind of got to suck it up and deal with it, and we're not a Amazon type thing. But I do think there is, if you really sit down and look at each step, there's probably a lot of ways we could do things more efficiently and help the patient, to have a more streamlined, quicker experience. I mean, maybe it doesn't work out for every tooth, every patient situation, but there's probably a lot we could do for most patients. So I like how you're steering us in that direction.
Well, I think, as with anything, Grant, the more you do something, the better you get at it. And I think you brought up some really good points during our discussion with quality assurance, and how do you communicate effectively to the patient and to your team. And that seems to be a little bit of a barrier. And then also just getting the technique down. The first few that you do, you might start to put the implant in and you just go, I don't like that. I'm going to take it out and I'm going to graft it. But I think the more that you do that, having good communication with the patient so the patient knows there's some variables there, you're going to get better at it over time and you're going to become more confident with it. And so, you know, the best way to do it is start today. And if you're a little unsure, go to a course or find somebody who's doing it well and then have them teach you. That's how I learned it. I had some great mentors early on that taught me how to do it, and then I've kind of evolved over time. Uh, and I think, going back to what you said, just making the entire process easier. And, I think like when people ask me, how did you build this practice, and do so many implants and hit the revenue levels that you have? Well, one, I learned from some great mentors. But two, I've always kept just the patient experience kind of at the forefront of my mind. And I think it starts with the referral. If you hand somebody a piece of paper, they're going to go put it on their nightstand or it's going to end up in the laundry. And the NIH has a recent study that 50% of those people are never going to schedule their appointment. So how you refer that patient is really important. Like, get that patient scheduled before they leave the office, and they're going to have a 50% higher chance of scheduling. And if you can't schedule them, make sure that when that patient gets scheduled, that timeline is as short as possible from when the referral is made to when they get into the surgery schedule. And there's a lot of studies that show that the shorter that distance or the shorter that time period, the higher likelihood they are to schedule. And so you look at it in percentages, 50% higher scheduling rate when the patient is scheduled efficiently. If you put a referral in a cloud somewhere or on somebody's email inbox, that patient's already forgotten about their care, and you've lost that patient most likely, or you're offsetting that patient to your competition in your community. So having that, and I know I plug Doctor Talk, but we use it so much, and it's such a great business tool. When that patient's referred, you get a call to action that just pops up on your computer. Hey, we've sent you a referral, and you're able to just realize that referral immediately. So that's a percentage. And then if you graft and you stage something, that 40% number is real. I've confirmed that in my office, and a lot of my mentors that I've mentioned in the podcast, that number, people that don't come back to have the implant, they just get used to their partial edentalism. They get used to not having a tooth, and then life happens. So I think being able to provide that solution same day is a great service to the patient.
Oh, sure. 100% agree. What do you have any final thoughts on kind of the essential components to success when doing surgery? Any final concluding thoughts on that one?
Yeah, I mean, I think we talked a little bit about surgery, and I think you've asked really great questions today about quality assurance and technique, and communication with the patient and the team. I think probably something that I don't know if I mentioned this, but just do a quality assurance check with your implants. Don't just say, okay, you're done, go back and have it restored. But, have the patient come back for a surgical release appointment where you test the implant, where you look at the soft tissues. And, if it looks like your restorative colleague is going to have difficulty putting that tooth into a really narrow area that has thick tissue and bones grown up over the platform, take a few extra minutes to, create hard and soft tissue emergence that's going to make it easier for the restorative dentist. So I think, we always think about surgery. I think about my restorative colleagues' experience. And if that's a great experience, and if they're profitable and it's easy for the patient, that patient's going to come back, or that restorative colleague's going to send the next patient to me because I made it easier for the dentist. And we've got so many great abutment options nowadays. You talked a little bit about anatomic scannable abutments. Those have really changed the game. If you have a regular abutment, maybe your platform's a little deep, take an extra step and make a custom abutment that just pushes everything out of the way, so that when your restorative colleagues drops that tooth in, it's an easy process for them. So I think that's you asked about technique. I don't think it's just the technique at surgery, but it's also the technique and the experience for the patient and the restorative doctor.
Yeah. Yeah, I found that as well. That's a great tip as far as once the healing process is done, doing that check where it's more than just, yeah, you hit the time limit, okay, go and get the crown.
Right.
Because frequently, like you're saying, yeah, we'll have to maybe remove some bone or contour the bone, soft tissue a little bit. And then just little things that take maybe 5 minutes can just save the dentist the world of headache and having to, try to do a crown, doesn't work. Okay, send it back to the surgeon. I need you to remove bone. I need you to do this. It's so much nicer if we can just get that taken care of before they do their crown work.
Yeah, I do some consulting for surgeons and teams around the country, and everybody always says, I'm down. My numbers are down. I'm not as busy as I want to be. And my first question is, how are you capturing your referrals? And they aren't they don't have a system for capturing the referrals. So literally surgery that they could be doing is falling through the cracks. And then the second thing is, what are the solutions you're offering to your patients? Are you staging things? Are you offering immediacy? And I think those two things together drive practice growth like tremendously. And I see as much as 25 to 30% year over year growth when practices implement intelligent referral management and immediacy to their dentists or to their patients.
Wow, that's phenomenal. Well, Tom, thank you for running through this with us. This has been just awesome to talk about, and I think incredible, content and kind of information for our listeners. So if you're good with that, as usual, I can put your contact info in our show notes. And if there's further questions, maybe our listeners could reach out to you or to me as well. But I appreciate you doing this.
Yeah, that sounds great. It's always good to visit with you, Grant. Have a great day, and we'll talk soon.
Sounds good. Thank you.
All right. See you. Bye.
Bye. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.